You'll see that these are the two axes. The vertical axis is what Bill mentioned before on the diagnostic severity, so some classification of the different clinical conditions that a variety of neonates would have. And the horizontal axis at the top, measure prematurity. Here we have birth weight listed. And what you'll see here, what I'm going to just describe briefly, is just how the APR-DRGs work, and from that I will describe how we use that to come to a manageable number of different segments of clinical severity within the neonatal population. So you'll see I know the text is a little bit small, so bear with me here, but I'll just read a few of the descriptions so you have a sense on the clinical diagnostic severity dimensions. So you'll have normal newborns or neonates with other problems, neonates with other significant conditions, with congenital and perinatal infections. Each of these things has a number of, kind of diagnoses codes underlying that. So you can see, if you look at the thousands of diagnoses codes that a neonate could have, the DRG tools have bucketed these into different categories. On the birth weight spectrum, you can see this is kind of ordered from least premature or greatest birth weight down to, the really, really small babies. So greater than 2,500 grams, to the 2,000 to 2,500 grammers, 15 to 2,000 grammers, etc. And it's not too important to understand what all these numbers are, but suffice it to say that the APR-DRG, through kind of lots of historical analysis on many, many data sets, and we went through a lot of the stuff with John Bates as well, has groups of these things. So, for example, APR-DRG 640, which is the top left of this chart, is basically the DRG that encompasses basically your normal newborn. They've got no issues for the most part, and they're over 2,500 grams. DRG 626 is also for a normal newborn from what we see in the claims data, but that baby is between 2,000 and 2,500 grams. So you can see there's a spread of, roughly 30 of these different APR-DRGs, but the idea is that these have been, with clinicians and a lot of historical data across the country, a way to try and segment the neonatal population by different parts of severity and prematurity. So that's what the APR-DRG is. If you look at what we're about to walk through, then allow me to walk through some of the pages, and hopefully this will become more clear. You can see that each of these rows, which has a common clinical severity on the left-hand side, but spans a range of prematurity. On the right-hand side, we've given that an episode name, so think of that as a sub-episode. So all the normal newborns, that row, we call that episode segment A. And because there are those two things shaded on the left-hand side, 626 and 640, basically episode segment A represents babies that are normal newborns and anywhere between 2,000 and above, 2,000 grams and above. I'll pick one other example here. If you look at the sixth row down, with RDS, or another major respiratory condition, that row is a clinical categorization, and this particular row has babies anywhere from 1,500 grams and above. You'll see that represented by the blue buckets in 612, 622, 634. For this row of this clinical categorization, you'll see episode F listed next to this. So the point of this is, if you flip to the next page, without having to look through every single matrix of that cell of that matrix, the point is there are a lot of tools out there that have done a lot of clinical and other statistical analyses on lots and lots of data across the country to really find what are more comparable segments within the neonatal population. And that is summarized on page 17, the bucketing that comes out of that. You'll see A through N. Each one of these episodes here that are listed represent one of the rows on the prior chart that have a common set of clinical conditions. So A, B, C are some of the ones we just talked through. You can see the range of birth weight that the APR-DRG includes in that bucket. So episode C with congenital or perinatal infections, babies with diagnosis codes that fall into that bucket, This episode segment includes babies that are over 1,500 grams. So a few other points I'll just mention on this page, and I know there's a lot of information coming here, but for each of these segments, you'll see two columns of data on the right-hand side. The column that says the number of annual episodes, this is for the Medicaid population in the given year, is how many episodes there were. So there were 5,700 normal newborn babies, with the clarification that I'll come back to this, there's another level of severity segmentation underneath that. But severity 2 and 3 means they have some complication of some sort. They're not just they don't leave the hospital with no scratches. There are 5,700 of those for Medicaid in a given year. And likewise for episode segment B, there are 560. And the column on the far right just breaks down the percent of Medicaid spend on neonatal care in a given year that is for that episode. So that's how to read the chart. What you'll see with the brackets is that essentially episodes A through G, the first 7 of those, are the ones that are they're not normal newborns that have no scratches or anything on them. And there's enough case volume, at least 150 or so cases per year for Medicaid in each of these each of these segments. The segments you see below, some of them get more complex and other things like that, and the case volume starts to get smaller. So for example, in episode J with other major procedures, we didn't obviously show the list of all of them just for space, less than 2,500. They're much more complicated conditions. There are only 82 of those for Medicaid in the year. So those kind of are not being addressed right now. But it's the top 7 that are being addressed. And as Bill mentioned earlier, the very last row of this table, episode N, normal newborn severity 1. That's basically kind of as straightforward as it gets for a perinatal case. There are 15,500 of those for Medicaid in calendar year 2011. As Bill said, those are not kind of the focus of the neonatal episode here. So I'm going to go through one more page before I pause for questions. I think you'll need to look with me at the screen because the black and white printouts, it's a little bit hard to see. So remember on the prior page, I walked through episodes A through N, all around kind of different severity levels and clinical bucketing. And you'll see here back to the overall framework that we talked through last time with this work group, diagnosis-based complexity level and the level of prematurity. We kind of mapped out each of those episodes on this chart. So for example, episode A, it's kind of roughly a medium severity neonatal episode and spans, is addressable for neonates kind of 2,000 grams or above. And the ones highlighted in blue are the 7 I mentioned on the previous page that are really the focus right now for this initiative of the neonatal episodes. You'll notice they're kind of the middle 2 levels of severity, and they are primarily focused at 1,500 grams and above. There's some that get into the 1,000 to 1,500 grammer range. There are a number of episodes that are the highest complexity babies, those kind of clinical categories, or the ones that are under 1,000 grams. Those are not being addressed right now as the focus for this particular initiative. It's just the 7 that are highlighted. You'll also see N at the top, the lowest severity normal newborns above 2,000 grams. The 15,000 of those for Medicaid. Blue Cross has a large number of those as well. That's not being addressed right now, this initiative.
We had discussed in our work group about increasing the granularity. We talked about babies tend to be discharged at or around 37 weeks adjusted age, whether they're 29 weeks, delivered at 29 weeks, or 34 weeks. And I think we had decided to go with birth weight and to correlate that with gestational age because we couldn't get an accurate gestational age. Is that correct still?
We are looking at gestational age to see if that further augments the model, but you're right. We looked at the data and correlated gestational age and birth weight and the number of cases for which that was available and how well they, it predicted cost. And they were really, really, really close when you look at the kind of correlations. So we're still actually looking at gestational age to see if there are further ways we build that into how we adjust for different case mix and risk. But if you look at page 17 for each of these categories, A through N, These are the roll-ups of the DRG, as I mentioned. Underneath each of these DRGs, I mentioned 640 before, there are actual further severity levels that take all the clinical conditions that are in that group and other factors, and based on a lot of analysis, can come out with a further severity level. You can think of it as 1, 2, 3, 4, with 4 being the most severe. So even if you have a bunch of normal newborns that there's nothing there's not too much significantly in terms of complications or issues with them, and they're above 2,000 grams, there's still some range of severity within that. And so episode N, you'll see severity 1. That's literally the most basic. They basically leave the hospital without a scratch, so to speak. That's the 15,000 episodes. Segment A, they're normal newborns in the sense of there are no kind of diagnostic. Sure, yeah.
Yeah, I was going to say maybe the better term would be they're term newborns. Yeah, instead of normal, and then they have some issues at term. Yeah.
So if category N is normal newborn with a severity 1 problem, where's the normal newborn with no problems at all?
Severity 1 is basically the no severity, the lowest point, the typical, yeah, which is why you see 15,000 of those in the state.
Okay, so now that we have the big framework available, and at least on the table, we start looking at episode designs for these different groupings of populations of neonates. And on pages 20 and 21, this is a pretty standard way we go about defining episodes for the other episodes of care. So we have to have a trigger. In this case, it would be a live birth. And so you'd have a variety of diagnoses, but it would have to be that someone is born. And then we create different episodes based on the APDRG and the birth weight, as we've been talking about, so the presentations. And then we have the time frame for the scope of the services. So here it would be the day of birth until, in this case, we're going to talk about 7 and 30 days post-discharge. And the reason we've done that, and we'll show you later on, is in terms of costs. We will include any child who has been readmitted, costs involved with readmissions within 7 days. And we will also be giving feedback about what happens within 30 days. But the 30-day segment is only for feedback, but the 7-day window of readmissions would be included in the episode costs. And we can talk about things about appropriateness of discharge timing, handoffs, etc. We will exclude transportation costs. So people being transferred to another facility or being back transferred, those costs are not included. We exclude certain cases. So we're going to exclude children or neonates that die during the episode, children or neonates that are taken from the hospital against medical advice by family, parents, etc. Dual coverage situations, multiple births, obviously greater than 2. So triplets or greater, out of hospital births, third party liability, which is secondary coverage. The patients who don't have continuous coverage during the episode, people who, I don't know what an incomplete transfer refers to, but perhaps.
Occasionally in a claim, patients will have a discharge status of transferred, but you won't see a subsequent claim. And in that case, we're considering those incomplete transfers, so you don't see the full duration of the episode. And for that reason, we're considering them incomplete episodes.
So billings that don't make sense. That's right.
Precisely.
Okay. Good. We will not count things that don't make sense. So, episode adjustments, we will do some severity. Obviously, the APDRGs does some severity adjustment, and if a patient is transferred, that actually increases complexity, and there'll be an adjustment for the fact that the patient was transferred. And then we have other clinical factors. Next page, you'll see the quality metrics. So we're going to be doing things like, and this will be gone into more depth later, the rate of bronchopulmonary dysplasia, the rate of hearing and metabolic screens, 7-day follow-up, whether the children are getting seen within 7 days of discharge from their neonatal care episode. Some will only be for those 3 metrics would be for gain sharing. There'll be some quality metrics for reporting, mortality rates, infection rates, NEC rates, which are currently very low. Other metrics include number of days on the ventilator, frequency of chest x-rays, adjusted length of stay, intensity of care duration at each care level, so how decisions are made to reduce intensity of care, percentage of full-term neonates that get transferred, and then rates of breastfeeding, which is ongoing activity at statewide, but also some activity in terms of reducing NEC rates and breastfeeding or donor breast milk feeding during the care in the NICU. And again, we're going to talk further about who is the PAP, and in this case, it's going to be a co-PAP because the physicians as well as the institution, who are separate payment, if you will, payment buckets, have equal say in a lot of things that go on. So the physicians are making a lot of the medical decisions and resource deployments, while the institution and its nursing structure is making important decisions about intensity of service, location of service, and follow-up care kind of activities.